In accordance with the customs of this university, I open this ceremony with the following words. Spiritus Sancti Gratia Illuminet Sensus et Corda Nostra. Please take your seat. Welcome to you all, specifically Widhi Adhiatma, with I wish success in the defense of your thesis. Welcome to the supervising team, Professor Kessels and Dr. Hendricks from this university, and also Dr. Halim from Atma, Jaya, Catholic University of Indonesia in Jakarta, She will join us by Zoom. All other people attending this session by Zoom, a very warm welcome. And I also welcome one other person, Professor Koenen, long-lasting involved in the collaboration with the University in Jakarta, and he is here also attending this ceremony. The other persons behind these tables I will introduce as we go along. I am the chair, Professor Ruud Meulenbroek, and I will try to keep everything under control, whatever that may mean. But I'm sure it will be an interesting session, and I will now, according to the procedure, give the floor to the candidate for the degree of doctor.
With the permission of Dr. Radboud, and in order to obtain the degree of doctor from Radboud University in Nijmegen, I would like to defend in public my dissertation entitled The Development of Performance Validity Test for Use in Neuropsychological Assessment in Indonesia. Maybe some of us have taken a fasting blood glucose test to measure the levels of glucose or sugar in the blood for screening diabetes and problems with insulin functioning. It would be best to have fasting at least 8 hours before the test. Otherwise, our test result will display a higher glucose level. In this case, the fasting blood glucose test gives an invalid glucose level results. The concept of test validity also exists in clinical neuropsychological assessment called performance validity. I want to give one example that shows the importance of performance validity in clinical neuropsychological assessment. Imagine a young man experienced a bump on his head. The brain scan indicated no serious damage to his brain. While taking the cognitive test a year later, he felt very anxious if he had cognitive problems due to the incident. His anxiousness finally caused him to make some mistakes. Suppose the man's cognitive test results indicate cognitive problems because of some low scores. Would you believe the test gives valid results? Interpreting invalid test results will generate inaccurate conclusions regarding the nature of patient's problem. In this case, performance validity testing is necessary. Performance validity test resembles neuropsychological domains measures such as memory or processing speed, as if this test appeared to be difficult. However, PVT is constructed to be considerably easier to complete than the actual neuropsychological tests that measure cognitive performance, so that even most patients with cognitive impairments can pass PVT. Two types of PVT are available for use in clinical practice: the standalone PVT, which is specifically constructed and administered to measure performance validity, and the embedded PVT, which is derived from an existing neuropsychological test that was not primarily developed to test performance validity, but, for example, relies on floor or below chance performance that rarely occurs even in individuals with cognitive impairments. The main feature of PVT is the ability to differentiate performance in completing the neuropsychological or cognitive test scores between people who take the test seriously and those who do not, which I label as invalid performers. The main feature can assist clinicians in objectively ascertaining the validity of neuropsychological test scores. Clinical neuropsychology experts reach a consensus that highly recommends using PVT in clinical neuropsychological assessments. In addition, they also encourage the utilization of multiple PVTs to improve diagnostic classification accuracy. However, it is unfortunate that this type of test is not yet available in Indonesia, making the validity of neuropsychological or cognitive test results questionable. To address this issue, I adapted multiple PVTs to be used in Indonesia. I adapted both standalone and embedded PVT, that is the Nonverbal Medical Symptom Validity Test or NVMSVT, Tes Memori Jangka Pendek Indonesia or TMGPI, which is developed based on Amsterdam Short-Term Memory Test or ASTM, and some validity indices of digit span. Those are the reliable digit span or RDS, longest digit forward 1 trial or LDF1, and longest digit forward 2 trials or LDF2. The NVMSVT is a non-verbal computerized PVT using pictures as stimuli. This test contains recognition, association, and recall tasks. In addition, performance consistency is also evaluated in this test. The TMGPI uses words as stimuli. All words are in Bahasa Indonesia. In this test, 5 words from a particular category, for instance animal, are presented first to the examinee. Then it was followed by a simple arithmetic task as a distractor. On the next page, 5 words from the same category as the first page appear. The examinee should identify 3 words that have appeared previously. The digit span used in this study derives from the Indonesian version of WISE-4. I used the forward trial, where the examinee should repeat some numbers mentioned by the examiner, and the backward trial, where the examinee should repeat the numbers in reverse order. The RDS score is obtained from the forward and backward trials, while the LDF1 and LDF2 only use the forward trials. In the first study, I administered the NVMSVT and TMGPI to healthy participants with various demographic backgrounds. While the PVTs were not affected by participants' demographic backgrounds, I found that 3.8 of participants did not pass the NVMSVT, and 2.1% of participants did not pass the TMGPI when the traditional cutoff scores were applied. The following study was a simulation study involving healthy undergraduate students, where I divided them into 3 groups, namely naive simulators, warned simulators, and honest controls. The evaluated PVTs were able to differentiate between the control group and simulator groups with outstanding diagnostic accuracy. This simulation study also proposed cutoff scores which could optimally differentiate between valid and invalid performers. The NVMSVT required lower cutoff scores than the traditional one, while the TMGPI and RDS proposed higher cutoff scores. However, the absence of clinical patients in this first empirical study raises further questions. Can these evaluated PVTs be used in clinical settings, that is, in people with genuine cognitive impairments? Furthermore, can the proposed cutoff scores from this study be used in people with genuine impairments? This issue is crucial because mislabeling a patient with genuine cognitive impairment as an invalid performance, called a false positive, will hinder them from receiving necessary treatment. There is also a risk that the patient might be accused as a liar. For this reason, my subsequent 2 empirical studies investigated the evaluated PVTs in an Indonesian sample of mixed neurological patients and Indonesian in patients with schizophrenia. Both studies aim to identify the most optimum cutoff scores with the lowest false positive rates in clinical patients in Indonesia. In the neurological patient study, I divided the participants into 3 groups, namely patients with a neurocognitive disorder due to possible neurocognitive disease, or ND, patients who have had a stroke, or PS, and a mixed etiology group. The results indicated neither my simulation study nor the traditional cutoff scores yielded acceptable specificity rates. Therefore, I lowered the cutoff score for each PVT, with the most significant cutoff score adjustment occurring in the ND group except for the NVMSVT. In a similar vein, the cutoff scores derived from the simulation study and the traditional cutoff scores resulted in unacceptable specificity rates in Indonesians in patients with schizophrenia. Therefore, all evaluated PVTs required cutoff scores. However, substantial cutoff score adjustments were detected in the NVMSVT, TMGPI, and RDS. These PVTs might not be suitable for patients with severe psychiatric disorders, such as in patients with schizophrenia. The adaptation process indicated that the evaluated PVTs had outstanding diagnostic accuracy and could be used in clinical settings in Indonesia with some cutoff score adjustments. As reflected in my studies, cognitive impairments experienced by patients affected their ability to complete the PVTs. Therefore, the use of these PVTs in people with severe cognitive impairments should be managed cautiously to minimize inaccurate interpretation. In addition, Indonesian clinicians who want to use these PVTs should pay attention to their patients' demographic backgrounds. My study found that few healthy participants did on their best ability, but scored low on PVTs. These participants did not seem to comprehend the task well, but were reluctant or shy to ask. This indirect way of communication is common in Eastern culture, such as in Indonesia. Therefore, clinicians should know that patients' demographic background might affect the PVT score. Thank you for your attention. Terima kasih. Having presented the summary of my dissertation, I return the floor to the rector.
Thank you very much for this clear introduction. I would now give the floor to Professor van der Heijden, Professor of Multidimensional Psychodiagnostics of the Behavioral Science Institute of this university. Professor van der Heijden.
Thank you. Congratulations with your dissertation. I want to especially I would like to express my appreciation for the collection of two unique samples with patients that are usually difficult to include in practice-based scientific research. I think you make valuable recommendations for clinical practice that follow directly from your findings. And as a clinician, I would like to ask you two questions from a clinical perspective. Regarding Chapter 5, you write in Chapter 5 about the base rate of underachievement in patients with psychosis spectrum disorder, about 18%. And then you have a specificity of 0.19, where your cutoffs are based on. So I wonder if you were a clinician and you were confronted with a patient with a score under the cutoff, how do you take into account the base rate of underachievement in this particular group of patients?
Dear opponent, first thank you for your appreciation on my on this project, for my project. If I understand correctly, so you asked about what is my opinion if I meet or facing patients with below cutoff scores, and what should we do or I do as a clinician, if do I understand correctly? Yeah. Mm-hmm. First, as suggested in my study, so apparently the severity of the patient symptom really affect their performance on PVT. So first, I should check, is it, let's say, inpatient or outpatient? The context should be clear first. Even if it's inpatient, how long they already take the medication? Or also, first, based on the behavioral observation, how visible is their, let's say, positive symptoms or negative symptoms? And let's say if everything is quote-unquote fine, these patients can be given the test, and then the patients obtained below cutoff scores. I will check again how many PVTs that already used. Let's say they failed in more than 2 PVTs. I would suggest their performance is invalid.
Okay, thank you. I have another question. There seems to be a large gap between the cutoff score for the reliable digit span for the naive simulators in the first empirical study, Chapter 3, and the cutoff score for the reliable digit span for the patients with schizophrenia spectrum disorder, Chapter 5.
Yeah.
What is your hypothesis about this finding, and to what extent do you think that the fact that the effort of the patients is just for scientific research plays a role? You do not mention this in your discussion. In addition, probably most simulators are not entirely naive. Yeah. So what would you advise clinicians to do when confronted with a patient with a mild psychosis spectrum disorder and a possible secondary gain?
Okay, so first, what is my hypothesis regarding the results of the naive simulator scored lower than the schizophrenia in patients, I think it can give me two impressions. The first, because as the group's name is naive simulators, I did not give any briefing or instruction for them to simulate the invalid performance, and that's my first impression. And my second impression is also give me the picture of in patients with schizophrenia's performance. I mean, in my opinion, there even patients with schizophrenia, and we know that schizophrenia is a severe psychiatric disorder, their performance is not that bad. That's my answer. And may I ask you to repeat your next question? Because,
Yeah, so the first question was how do you explain the gap between the two?
Yeah.
And the second question is, to what extent do you think the fact that the efforts of the schizophrenia patients is just for scientific research, because they didn't have any advantage for taking this test?
Yeah. I think based on, first we should know that in determining the cutoff score, we used like the rule of thumb is 90% specificity rates. But actually, if I check my data, around, if I remember it correctly, around 70 or 80% schizophrenia in patients, my samples, they can pass the test. So actually, not all schizophrenic patients perform worse. And even I can say the majority of patients, schizophrenia patients, they can perform in their best to take the neurocognitive test.
Because it seemed to be there were a lot of extreme outliers also.
Yes, correct. Even if I may add some story about my data, I have one or two participants that scored in the floor level. Mm-hmm. So in that case, I assume his performance is invalid, clearly invalid. Perhaps because we collect data, and I mean, their participation in my research is based on voluntary. They don't get any benefit. Mm-hmm. Perhaps they expect, I will leave the hospital if they don't have that kind of motivation. Perhaps some extreme participant just, I don't care with this test, I just do it and finish, and their performance finally extreme near the floor level. But that's not that many. Yeah.
Thank you very much. Then I now give the floor to Professor Pons. He's Professor of Medical Psychology and Head of the Department of Medical Psychology at the Academic Hospital in Amsterdam. Professor.
Thank you, Will. Thank you very much, Mr. Pro-Rector. Dear candidate, first of all, my congratulations for your thesis. A difficult one, because you did all the work in COVID time, as I just understood.
Correct.
Extra difficult. Another thing is that we are somewhat related, could be related, because in 2009 I was planning to go for my sabbatical to your university. But for the easiness of language, we went to Kenya, so something different. Okay, you know, I'm already for 20 years involved in this topic, also in research and clinic, and some ambivalent relationship with this topic, because it's very relevant, clinically relevant, but it's also very complex in terms of research and concept. It's a kind of minefield. But anyway, it's interesting. I have some questions for you. And the first concerns your simulation study, and especially the scenario you used. It's quite an extreme scenario, more or less a criminal scenario, because there's an attorney who's a crook. He says, you have to cheat the psychologist. And the patient, or the simulant, you say, you have to cheat the psychologist. And they give you even 3 days to learn how to do it. Go on internet and learn this. And the results of this simulation design, the cutoff score, so to say, you use in 2 clinical samples, in chapter 4 and 5, I think. And there you have a problem, because these cutoff scores are problematic. You have to adjust them. Do you think, or if you should rethink your simulation study, you could probably choose for a more realistic, more patient-related, clinically related scenario? For example, a patient who is thinking, well, I've been to 7 doctors now, nobody takes me serious. And you ask the patient, well, try to convince the doctor or the psychologist that you have a serious problem. Because this is mainly what happens in clinic. Not this criminal scenario. It's an extreme case of malingering, of course, and a clear case of malingering. But your thesis is not about malingering.
Dear opponents, that's a very critical question and also suggestion. I appreciate it. So first, I agree with you. My scenario is not was not really relevant for clinical settings because it's clearly malingering. But why did I choose to use that method? So first, at that moment, I thought how to ensure that my participants can show invalid performance. Otherwise, let's say I already recruit 200 participants and most of them, they do well. So finally, my test cannot discriminate between these groups. It would be problematic. So I should make the case, I should ensure my participants really show invalid performance, not necessarily malingering, actually. In Indonesia, there was a famous case about a famous person that tried to pretend for being a head injury and memory problems. I got inspiration from that case, so I can ensure my participants can do the role play as I expected.
But it's still an extreme case.
Yes, I agree. It's very extreme case. So if you ask me, what could I do if I can do my PhD again?
Oh, at least this study.
Yeah. I mean, first, perhaps I can redesign the scenario, but of course.
How would you redesign it?
Yeah.
What would be more?
I will make perhaps first with claimant scenario to claim, let's say, insurance, or even I would say it's more extreme, like ask the participants to simulate patients who had so many complaints, but actually the medical doctor already said you're fine.
Yes.
But to run the simulation, I think I should run some pilot studies first, because I will worry my participants they don't understand the instruction well.
Okay.
Yeah, but I agree.
But the
with
scenario
your
was
suggestion.
very successful.
Yeah, because it's really related for Indonesian.
Extreme low scores.
Yeah.
Okay. It's time for a second question.
Short.
Yeah. Short question. This use of PVTs in also cognitively severe samples, or even the schizophrenia sample. What would be the reason to use PVTs in this sample after all? Because an exclusion criteria for the use of PVTs is severe cognitive disorders. Because if there is severe cognitive disorder, the PVT change in a normal memory test, more or less.
Yeah.
So why would you use PVTs in these samples?
Okay, so first in my design, I used different type of clinical groups. The one with more severe in psychiatric settings, and the one with more severe in neurological settings. So for the psychiatric settings, it should be the schizophrenia and depression, but unfortunately my depressed patients only 11, so we discussed to exclude them. But why it's important for me? It is important to put the severe cognitively impaired patients in the research, because when we meet patients in real clinical settings, and we know that the patients is not that severe, their cognitive impairment is not that severe, and they obtained a lower score below the our cutoff scores, it's a very clear sign of invalid performance.
I totally agree. But what about the severe cognitive patient? Severe cognitively impaired patient.
Mm-hmm.
You don't know what a low score means, isn't it?
Correct.
Is it lack of effort? Is it
Yep.
genuine cognitive impairment?
Yeah.
I think. I already told you it's a minefield. We don't know how to use it in practice. Even after 30, 40 years of research, it's complex.
Yeah. And it's very hard to interpret.
Very hard.
Yeah. Either they have a very severe cognitive impairment and then they fail, or they choose to show invalid performance and then they fail. It's very difficult to interpret the results. Okay. But the one thing is clear, I think their performance is invalid, but why? That's the most challenging part.
Okay,
yeah.
Thank you very much. Thank you very much.
Well, I'm glad you agree on this. Now we turn to contribution by Dr. Suwartono from Atma, Katolik University of Indonesia. Thank you for joining us via Zoom. You're specialized in the field of psychology and psychometrics, and you are Vice Dean of the Faculty of Psychology. So we appreciate your role in this defense. The floor is yours.
Yes, thank you, Acting Rector, Prof. Radboud. Congratulations, first of all. Overall, I'm impressed by the candidate dedication and commitment to advancing the field of clinical neuropsychology in Indonesia through this dissertation. And for this, I have some of questions. The first question is like, do you discuss about, do you consult the process of the adaptation with local clinician, researcher, or psychometrician in Indonesia during the development and validation of the PVTs? And how did their input influence the adaptation of the assessment tools to align with the Indonesian context?
Dear opponents, first thank you for your compliment on my effort in completing my project. So the adaptation process. So I used 3 tests in my study: the NVMSVT, and then the TMGPI, and the validity indices of digit span. From these 3 tests that required adaptations, or perhaps I don't think it's adaptation, it's more a developing a new test, is the TMGPI, because this test derived from the Amsterdam short-term memory test, and during the process of course, I discussed with my supervision team, and they are clinical psychologists, also with psychometric expertise. Also with my supervision team is a clinical neuropsychologist. So yeah, I consult with them about the adaptation process. But for the NVMSVT, it's a non-verbal test. So all the stimuli, it's given. And so even the test publisher did not permit any modification of the stimuli, so I just left like that. But I can give some comments, and fortunately, my participants, even in the clinical settings, they can understand the stimuli. And I have to say, I have to thank to you, because I used the digit span that already developed by you several years ago, so that's really helped. Thank you. But yeah, basically that's the process. So I also consult with my supervision team, and their expertise is in clinical psychology, clinical neuropsychology, also in psychometry.
Do they have some inputs that you align with the tools?
Okay, it's a challenging question because it's already several years ago, and yeah, I think. Yeah. Like, oh, is my presentation already gone? If you still remember about the TMGPI or Test Memori Jangka Pendek Indonesia, there are 3 pages in each item, and one of the inputs is like first the stimuli. There's a like this TV, radio, and blah, blah, blah. I forgot the next words, and we consider that we should not have written it as TV. Instead of we should write it as televisi, because the number of syllables with more or less more equal. That's one input that finally I revised the test.
Then can you elaborate on any challenges faced and strategies employed to ensure cultural appropriateness of the assessment tools, the PVTs?
Do you mean the cultural challenges for
Yes.
For adaptation or for what? Sorry, I don't understand.
The cultural challenges for the adapting the test, and how is there like any instruction difference, or how you administer the test?
Yeah. Okay. It's a very important issue to address, and like the NVMSVT, when I discussed with the test publisher, they said your test administrator just need to read the instruction as it is, and we face a huge challenge even in normal participants. They don't really sometimes they don't understand correctly the instruction. So because my team experienced this, so finally I asked my test administrators to, it's fine to rephrase in your own words. The most important thing is the participants really understand their task, so they can do the test well, and that's very challenging because as I presented before, some participants, healthy participants, fail the NVMSVT. I think that's the most challenging part, and also the challenging part for interpreting the test. I would say.
Okay. Yeah. Thank you. I give the floor back to the acting rector.
Thank you very much. Then we now turn to Dr. Koerts, Associate Professor at the Rijksuniversiteit Groningen and member of the Department of Clinical and Developmental Neuropsychology. Dr. Koerts.
Thank you. Dear candidate, also my congratulations for your very thorough work in many different samples. So it was really interesting to read it. I would first of all like to ask you a question, which is, well, not the last sentence of your thesis, but almost. You give a recommendation really in the end of your general introduction, just before the conclusion, which is that future research should validate PVTs that are not memory-based, such as mental processing speed or motor functions. This puzzled me a bit, and I agree that there should be PVTs that are not memory-based, but I'm wondering, why these two, and mainly why motor functions? I was wondering if you could explain that to me.
Oh. Dear opponent, so in my thesis, my main point is first, it's very important not just to have memory-based PVTs. So we should address other cognitive domains. Yeah, and why should motor functions also should be involved to be used in the clinical practice, especially.
Why do we need PVTs for that?
Yeah. Because in clinical neuropsychology settings, we also face patients with motor symptoms, and let's say like what's that? But basically, the cognitive domains experienced by patients not just the memory, but also include the motor functions. Perhaps in that case, it's also be good if we have the PVTs that address the motor functions.
Okay. Yeah. So, but I'm still wondering, the recommendations you give here, mental processing speed and motor functions, there are so many other cognitive domains. Think of executive functioning, visual spatial functioning, and so on. Why do you not recommend those? Why focusing on these two? Do you have argumentations for that?
Okay. Yeah? But actually, I agree with your suggestion. Basically, it's very, very good if in clinical practice we have all cognitive domains addressing those cognitive domains. So like PVT based on the executive functioning or PVTs based on attention. That's I agree.
You would include them all.
It will be very long if I.
I know.
That's
why I'm asking you. Where would you put the emphasis? So what would your recommendation be? Would you recommend them all, or could this differ?
Them all. I would recommend them all.
And would this then be the same for all patients, independent of diagnosis? Or would you say, okay, with a group of patients, I have a different recommendation than with another group?
I would say, again, back to the main symptoms of the patient. Let's say the patient have the impairments or deficiency or in motor area, or so it really depends on their symptoms, not just the diagnosis. It depends on the symptoms, because one diagnostic group can have a different cognitive symptoms.
So you would change your PVTs from one group to the next.
I agree with you.
Okay. So now I would like to move to chapter 5. First of all, let's see where it was mentioned. You mentioned there that this study used a differential prevalence design. And I was wondering, why do you call it a differential prevalence design? Because as far as I'm aware, and maybe I'm wrong, but a differential prevalence design would require people who are at risk for malingering. And if I read your participant section and also your procedure correctly, you excluded people who had in any way, or you had an indication for external incentives. So I would say they are then not at risk for malingering.
Okay.
So why do you call it then a differential prevalence design?
Oh, okay. Yeah. So I use these words from a book in that discussed about the malingering. There are four type research designs, and one of them is this differential prevalence design. So basically, this design, if I understand it correctly, we want to check the failure rate, or in other words, we can also examine the specificity rates in a clinical group. That's based on my understanding about the prevalence design.
Okay. Maybe I have to look it up again. It might also be
or maybe I will be wrong.
Yeah, we'll be both wrong.
Yeah.
Okay. Do you have time for another question? Yeah. Okay. So then I would like to ask a bit more also about the sample you included here, because these are all inpatients. And you basically show from going from chapter to chapter that you, depending on your sample, you have to adjust the cutoff scores. So I'm wondering, do these cutoff scores that you now developed for inpatients with schizophrenia, would they also apply to outpatients with schizophrenia? So who might be, well, not necessarily, but there's a chance that they have a less severe case or they are recovered. So how do you think about that?
I think it is reasonable if we use the cutoff derived from very severe patients with very severe cognitive impairment patients in less severe patients. It sounds reasonable, but I would take a very cautious interpretation in this case, because methodologically it should be researched first in those less severe clinical groups. But if we don't have any research about in the less severe clinical group, I think we can still use this. And with the interpretation, if the interpretation will be if they score below this, it's a like very higher degree of confidence that the patient is showing invalid results. But methodologically, it should be validated first.
Okay.
Or ideally and methodologically should be validated first in those different, distinct clinical groups.
So that's your next study?
Yeah.
It is. Okay. I give the word back.
Okay. Let's stay with the defense for still a few minutes. Thank you very much. We now give the floor to Professor Oosterman, Professor of Neuropsychology of Cognitive Aging at this university.
Thank you. Yes, I'm here at the back. So, dear candidate, I would like to continue first of all, the compliments that have been sort of given by my predecessor. So I really appreciate, really fully applaud the significant amount of work you did, specifically during the pandemic. I would also like to involve your team of supervisors in this, because it's a really impressive collection of different large studies and topics here. But of course, I also have some questions for you. And I think my main question sort of focuses on the role of education in your studies. So first of course, the work you have been doing, you have sort of highlighted the importance of cultural adaptation, showing right being the first, perhaps in Indonesia, to work on this. And I think one of the differences when you compare that country to the Western societies where the tests have been at least validated a bit more, is of course the level of education that people have or have not received or fulfilled. So could you help me out, first of all, just by giving me an indication of what is the average level of education in Indonesia?
Dear opponents, first, I don't have the data about this, but sorry, I had the data. I had the data from the Statistic Bureau of Indonesia, but sorry, I forgot about the average of education level. But if I understand it correctly, perhaps the average education is a senior high school. It's in Western culture. It's around 12 years of education, perhaps, yeah. But the other challenges is, I think, the education in Indonesia is not that equal. My point here is, let's say one participant has undergraduate degree from certain island, and other participants or other patients they're from other islands, but also with undergraduate degree level. Although we can say the educational background is similar, but quote unquote the quality is different. So that's I think the most challenging part, not just the what's the educational level. But yeah, my answer is perhaps in senior high school degree.
Well, thanks for informing me about those different regional differences you have also. So if I look at your different chapters, I see in that sense also a bit of differences in educational level between the populations that you included. Yeah. So for example, in chapter 3, I think it is still relative to the patient population, it's a relative high level of education. I see that in Appendix A. And to what extent might that have influenced the results you found? It's relatively higher levels here, so it could explain the ceiling effect you found. But also if you think about your simulation study, I can imagine that simulating, you did that really in just the undergraduate students, that the simulation might be really different in people with different educational background. So can you comment on how education might in those two different studies has influenced your results?
Yeah. The influence, I think the most prominent influence can be seen in the cutoff scores, because like as you addressed previously, in my chapter 3, the simulation study and the the study one from the first study from the chapter 3, the educational level is quite higher than in the clinical studies. So, in addition to the clinical factors that affect the different cutoff scores, I would say the educational variable also play roles in the results of my study, because the cognitive test is very related with scholastic experience. That's why it's very important to address. Yeah.
So, and how do you think your results in the simulation study would have looked like if you would have people with lower levels of education? Would that, for example, have impacted on the naive simulators or those that have been informed, or on both? And then which direction would you expect them?
Yeah. First, it can be, if I involve with more various degree of education in my participants in simulation study. First, it can be their performance. Their performance might be, it might be lower, but I think the more important case is whether they can simulate correctly. That's the most important thing to address. But it's difficult to hypothesize what will happen if I involve with different educational backgrounds participants. But so.
Might be an interesting future study as well.
Yeah, but with the risk they do not understand the instruction well. That's the challenging part.
Yeah, but if you would, for example, not have taken undergraduate students, but like the secondary school, that might also make a difference.
Okay,
right?
in that case, perhaps they can simulate much better, and their performance could be higher than my naive simulators. Yeah, that's my hypothesis.
And what is that based on? The higher performance?
Yeah, because I asked the participants to simulate, and they have time to prepare the simulation. I also explained there's a more incentive if you can be the best performer. So I assume the higher educational degree participants, they will prepare better than the lower degree education participants. That's my hypothesis. Yeah.
And then just a bit related to that, so in chapter 4 you have the different neurological groups, right? They also have different, I've just taken the table here on page 57.
Yep.
So they have bit of different educational levels. It's not significant, but you see the lowest levels, I think, those in the group with neurodegenerative disorder. Yeah. They are also older, I noted, and then you have the correlations between age and educational level and the performance levels, so the PVTs.
Yep.
So to what extent do you think those represent really education or age factor? Are they biased by the underlying condition?
Yeah, that's a very important issue to address. But first, my research did not answer that clearly. I can only set based on my data. Wait, I'll check in my. So, yeah, I would say it also depends on the type of the PVTs, because sometimes let's say in NVMS-VT, and NTM-GPI, or I would say the standalone PVTs, it's more affected by the age rather than the education, if I see based on my data. But for education, it affects all the PVTs. So we in clinical practice, we should address those two variables cautiously because it's clearly affect their performance.
And that's not mostly due to the condition that people have that you include.
Sorry, can you repeat it, Mama?
Well, it's a sort of the age effect is quite significant, right? But the older people also have the most severe cognitive disorders, right?
Yes.
Because they have they're apart from the ND group. For example.
Yeah, correct. Yeah. They have more severe. I assume they have more severe impairments.
So that could also be the cause here.
Yes. Yeah.
Given the time, I will leave it. Okay. It is? Okay, thanks.
Thank you very much. Then we now turn to Dr. Jongsma, Associate Professor at this university. Dr. Jongsma.
Thank you. Dear candidates, also from me, your congratulations on finishing. Oh, yeah. Dear candidate, from me also my congratulations on finishing your dissertation, and also to the supervisory team, Dr. Halim, Dr. Hendricks and Professor Kessels. It has been mentioned before, so a lot of this work has been done during the pandemic. We easily forget, and I think that shows, it gives a lot of respect to be able to finish it during the pandemic. And as I understood also from the dissertation, a lot of the data was acquired via Zoom. And I would like to zoom in on the Zoom acquisition and how valid this is.
Yeah.
So in chapter 3, you and you're very transparent, and I applaud that. That's really nowadays transparent and open science. You had planned that you want to have more balanced sample, but you described that you collect data via Zoom, but also a subsample of 68 participants that you collect the data face-to-face. And in your introduction, you already mentioned that the mode of administration might affect your findings. But there's another thing with the subsample. There are people living together with the examiners. So it's not only the mode of testing, it's also the familiarity. Now you start off really right, because you should question yourself, and you do that. Is the sample now different from the sample that I study online? And yes, you do find that they are different. And then this surprises me, you still combine them. So can you explain why you combine two subsamples that show a statistical difference in a test that we already know that has a ceiling effect because many participants reach a perfect score? How do you justify combining these two samples?
Their opponents. So first, there was a significant difference between those groups. Yeah, but first their effect is small, and then the second one in clinical practice. Let's say the TMGPI, the range score is between 30 to 90. In my data, the average score between the in-person participants and Zoom participants, one of the group is higher. I forget which one, but one group is higher. But this their average score, if we want to interpret clinically, both scores are still above 85. So basically, this difference in clinical settings would be not that significant, but it was statistically significant, but not for clinically. That's why it's still possible to combine these two groups together.
Okay, I'm still not very convinced, so I'm going to continue a little bit on this one, if you don't mind, even if you do mind, because you mentioned that out of 289 participants, 221 had a perfect score. Yep. Now, what you also very nicely explain in your presentation is that the people that did fail, the healthy participants, you had the observation that it was mostly due that they didn't really understand correctly the instructions and were shy to ask. I mean, it's also part of a cultural difference that I find really intriguing. But then I was wondering, isn't this the fact that maybe in a setting where it's face-to-face with somebody close to you, living in the same house, there wasn't a shyness and instructions were more understood. Now, these samples then behave differently. Which one do you think would result in more reliable cut-off scores to be used in an Indonesian sample or the population or in clinical practice? The Zoom participants or the housemates face-to-face?
Okay. I agree with you that for participants that their data collected in person, there will be some behaviors that different with other participants because they live together. Yeah, it will affect their behavior during completing the test. So if you ask me which score that can be applied, I would say if I want to focus more on the sensitivity, so let's say we want to use this test in forensic settings, so we really want to, I hope the test can be very sensitive. I will use the data from second study in the chapter 3, which was online, all of them are online participants, because I do not have any data that address the sensitivity issues. But if in clinical settings, I would suggest to use the my clinical data that were collected in person. Yeah.
Okay, yeah, thank you very much. Then I have a different question that is not completely related, and maybe a little bit language-based or terminology. But you explained beautiful in the introduction that there is two different kinds of performance validity tests. There is the standalone performance validity tests and the embedded performance validity tests. And then you also, and this is I think a nice escape route, you say they are derived from existing neuropsychological tests. And you keep that. However, you present them as being standalone. So my question is, can you still treat them as embedded performance validity tests because you take them out of their embeddedness of a full neuropsychological test battery or complete test? And if you present them as a standalone performance validity test, will you collect similar norm scores as if you would if you present them as an embedded performance validity test? So how valid are those outcomes?
Okay. First, I would still say it's embedded performance validity test because my RDS, LDF1, and LDF2 derived from the digit span subtest of WISE-4, and I did not make any modification at all in the instruction. But ideally, I should test the participants with whole battery. Ideally, in that case, it should be different cutoff scores that should be used. But because we don't have any data using the WISE-4 and we made a simulation study, I think my data still can be useful.
And you would still call them embedded and not standalone in this case?
Still say as embedded because the validity indices still embedded in the digit span subtest. It's very different with the standalone like the TMGPA or the NVMSVT because it's constructed specifically as a performance validity test. If I perhaps, let's say I modify the instruction for the digit span, it can be different test and could be a distinct PVT. That's my opinion.
Okay, thank you very much. And I would like to give
the floor. Return to. Thank you very much. This was the final question, and if I would allow others of the committee to continue with questioning, we would be interrupted. So I will not do that.
Ora est.
That's what we expected. Thank you very much. The defense is hereby concluded. I give the floor once again to the candidate.
Having defended my dissertation to the best of my ability, I would like to thank the rector and my supervisor and co-supervisors, as well as all those who have honored this ceremony with their presence.
The Doctoral Examination Board retreats for its deliberations. On behalf of the Doctoral Board of Radboud University Nijmegen, we have decided to award you the degree of Doctor. I invite Professor Kessels to discharge the task assigned to him.
With the power entrusted by law to the Doctoral Board, I hereby confer upon you, Widhi Adhiatma, born in Blitar, the title of Doctor from Radboud University Nijmegen, to which are attached all the associated legal and customary rights and duties with respect to academia and society. As proof thereof, I present you with this doctoral diploma signed by the rector and the doctoral thesis supervisor and co-supervisors.
The laudatio will be given by Dr. Hendricks. Please all take a seat.
Dear Dr. Widhi, and what a performance this is. And above all, what a valid performance you have made over the past 4 years. Of underachievement and malingering, I have noticed nothing, from the first contact till the night before last. Now, you all may think a bit ironically, and how did you measure this? It's clear after the defense that you should not go by your gut feelings, but in Widhi's case, we as a team of promoters have gathered enough clues to confidently rule out the possibility of false negative. The first contact with Widhi was in Jakarta, on one of my annual visits to Atma Jaya Catholic University to teach clinical neuropsychology. Widhi was one of the most avid and critical participants, and my colleague, Lena Halim, introduced him as a PhD candidate in the collaboration with Radboud University. Although I had an immediate valid impression of you, Widhi later said of this first meeting that he thought, I would think, what am I going to do with this shrill little man? He was wrong. Where I did get firmly mistaken was his interest in clinical neuropsychology. It was apparently not there then, and, in all openness, not there now. In the acknowledgements of your thesis, you may yet provide a clue to the confusion that arose the both of us. In the first sentence, you describe yourself as a wayward student in school. According to the Cambridge Dictionary, a wayward student is doing only what he wants and often changing his behavior in a way that is difficult to control. I may be a bad clinician, but I really don't think this description applies after 4 years. Nor have I experienced you as pushy at all. From the first WhatsApp on March 11, 2020, saying, just landed, I count 62 Zoom contacts in WhatsApp and have rather felt embarrassed that my schedule did not always allow me to make more time for you. The only message that could perhaps be called a bit pushy is the one about my assistance moving you to Okapi Street in Nijmegen. Because you didn't have your own transport. However, it turned out to be just one suitcase. And my efforts were neatly redeemed with a cup of coffee. The communication was quite a job for you, because at the first start of your project, the corona epidemic broke out in the Netherlands and later in Indonesia. So you had to direct all your colleagues from Nijmegen for the data collection. And later you also encountered problems with getting participants for your project. Hats off to you for these efforts. By the way, a very nice detail for those who are present here is that the nursery staff of the psychiatric hospital advised us to thank the patients for their participation with chickens and underwear during this period. What I also came to appreciate about you during this period is that you could cope very well with the social isolation we were all victims of, but you as a PhD from Jakarta in particular. As you thought that I went crazy with the question, do you have time to Zoom? You possibly went crazy with my question, how are you doing? Is it keeping up? You did manage to convince me eventually, though, that you could pass the time with your cat, your contacts in Utrecht, and relaxing by gaming on your computer. Even though you did everything at a fast pace and completed the PhD according to the planning, there's one thing that goes terribly slowly, and that is eating. In July 2022, without corona restrictions, you were allowed to give an oral presentation on your data at the INS in Barcelona. The evening before, we were supposed to have a quick bite to eat together, not too complex, quick pizza, so the presentation could be run through. It was a good thing we didn't stick to the culinary rules in Spain to start late, but went to dinner relatively early. Incidentally, this was not the reason why you had to travel alone to INS in Taiwan a year later, as you were again allowed to present at this congress as well. All in all, Widhi, congratulations again on getting your PhD on behalf of Roy, Lena and myself. You worked hard for it and very much deserve it. I'm very much looking forward to continuing working with you as a lecturer in Atma Jaya, starting in June this year, in the clinical neuropsychology course. Little by little, you will come to love my profession as well. Of course, congratulations also to your parents and your partner and all your family and friends who had to miss you. I promise you, he will be having dinner with you soon. All the best.
All right, before we're about to close this session, I would like to ask or provide Dr. Halim the opportunity to congratulate you from Jakarta. Dr. Halim.
Yeah, thank you. Dr. Widhi, so I'm allowed to mention the Dr. Widhi Adhiatma. I'm very happy that Well, finally you made it, and congratulations on your success in completing your doctoral studies as you had already planned from the beginning, I think. So you already mentioned to me, I would like to finish by before the 1st of March 2024, and now it's the 22nd of February 2024, so you really made it and you really deserve it. So enjoy your short holiday after this big event today before you will start a new assignment at the faculty. And all the best for you and also your academic career in the future. I would also like to congratulate to your parents and also your partner and all the people that support you for finishing this big project. Thank you.
Thank you very much. And also to Dr. Suwartono, an opportunity to congratulate you. Dr. Suwartono.
Yeah, thank you. Hi, Widhi. Dr. Widhi, now we can call you doctor. Congratulations, you are very on time. And then we will be very great to welcome you again to Atma Jaya after your holiday. Enjoy your holiday and congratulations again to your partner and to your parents and all who supports you. And congratulations also to Radboud and Atma Jaya. Thank you.
Thank you. All right. Dr. Adhiatma, also congratulations from the College of the Deans of this university. Our university really appreciates the long-lasting collaboration with Atma Jaya University in Jakarta, and from which already several successful PhD projects have emerged, like Dr. Halim and Dr. Suwartono, which is really a nice, almost historical line that will be continued. Congratulations also to your parents and friends and family and all who have attended this meeting. And I would like to close this session now and ask you all to stand. We close this ceremony with the following words. Gratias tibis artimus omnipotens Deus pro omnibus beneficiis tuis, qui vivis et regnas per omnia saecula saeculorum.
I hope the next meeting. Yeah.